Welcome all of you, Jean and Vineeta, for this webinar. This series on pandemic and public health learnings from the past and present are initiated by the Summer Resource Group for Women in Health and Gender Justice and Health Thematic Group of People's Health Movement. Summer works in the areas of health and human rights and social determinants of health, particularly women's health. And PHM is a global network bringing together grassroots health activists, civil society organizations, and academic institutions from around the world, particularly from the low and middle income countries. I was actually looking at the COVID official figures, and putting it official figures. Worldwide, till yesterday, it is 139.72 million. And in India, 14.29 million. And the city I live in, Delhi, it is 0.78 million. And then, in Maharashtra, which is much higher, 3.64 million. What does it say to us? Because without talking about it, I thought, it will be a little incomplete, today, the kind of situation where we are in. In India, I'm talking from the Indian perspective, the reports from the ground are giving a very, very grim picture. It seems our health system is still nowhere in a position to take care of the deluge of patients. Even now, doctors are crying themselves hoarse about the lack of basic amenities like oxygen, still not enough beds, not enough ICUs, or graded as ICU beds, oxygen beds, not enough testing kits, oximeters, or even vaccines. I wonder, where did the entire concept of preparedness dissolve? The manner in which focus was given on vaccines, it does not seem there was any dearth of resources to improve the other mitigation strategies. So then how is it that the health system is still plagued with the same deficiencies as the previous year in spite of the pandemic? So this situation is so unfortunate, and which is actually preventable, because we thought, after such a harrowing year since last March or so, we have been able to take some control of the situation with cases coming down, things opening up, beginning to get back to the normal, and vaccines coming in and so on. But it seems in the last few weeks, very rapidly, the situation has gone completely out of control. And once again, probably far worse than anything we have seen in the last 1 year. So what we are seeing is a complete failure of the state in terms of governance and accountability. I agree to some extent. Last year, it was caught unaware and it took certain decisions without thinking, with disastrous results. Last year, we thought we don't have the capacity. And 1 year later, we are saying we have no capacity to address the spike in infection and provide the basic, I'm talking about oxygen, to a patient. Why the state did not invest in capacity building in the last 1 year? Is there any change in the attitude of the state in this 1 year of living with the pandemic? There be, even with so much of scientific advancement, the virus seems to be 10 steps ahead of us. So the vaccines that the whole world has been looking forward to are still in trial and error stage. Also, we have become so engrossed with one aspect of the pandemic and its solution that we are not connecting the dots with many other issues that may be equally related, may be responsible for the situation in which we are today. So I think at every level, we are witnessing a large-scale reluctance to look into the past and learn from our mistakes that we committed in the past. It's becoming increasingly clear that we need to do so, and we have to do so. So as you know, we are witnessing the worst of our nightmares come true. It seems like the dystopian future that we have all been working against is nearer the present day reality that it ever was. Pandemics are not new. They have occurred many times in the past. It is only by looking deeper into those experiences in detail can we learn from them and plan more effectively for the future, and those learnings guiding us. So this first conversation, which was held on 30th March, where Prashant Kidambi and Dr. Carlo Cadov spoke, facilitated by Rama and Aditya. And on many of these issues, looking at the pandemics and the regulatory state. And we are happy to have a second conversation with Dr. Jean and facilitated by Vineeta. So I don't want to go much into it, but this is coming from what I'm experiencing right now in the city with, coming calls, receiving every minute, helpless patients, and it's not your own personal, it is much more, it is very much there. So with this, I really would like to, hope that, we will be focusing on the what we have thought of in this series. And I would like to invite my colleague, Chayanika, a science educator, feminist activist, to flag a few points from the previous seminar and introduce the facilitator and take the conversations forward. Thank you all. Thanks for participating. And over to you, Chayanika.
Thank you, Sarojini. And yes, I echo much of what Sarojini says. I think 30th March, Bombay was already where Delhi may be today. So, it is like that we are, and in that sense, I'm reminded of what Prashant Kidambi said, that there are waves of the epidemic as they come, and every wave is worse than the other. And we also, the state, of course, is, I would go a step further from Sarojini to say the state does not care, actually. The state is not bothered. The state is really interested in gathering people for snans of all kinds, for rituals of all kinds. It is not really interested in taking care of its people. But it's also us as citizens, of what we learn from history and what we learn from our experiences of the last 1 year. And I think last time when Prashant spoke, he spoke of Bombay so evocatively, and also speaking of plague almost a century earlier, speaking of areas, speaking of how the administration responded to the epidemic then, and you see the parallels now, which then were carried forward by Carlo, and he spoke more on this model of moving from prevention to preparedness and talking of a regulatory state, what is the role of the regulatory state in such a milieu where public health is not about prevention anymore, where public health is about creating capacity, and that capacity does not seem to exist across the globe. So one sees India in particular also in a very funny juncture at the moment, because it's becoming this global leader at various levels. It's trying to project itself as a very developed nation. At another level, it is completely undoing any kind of public health system or public education system. And I underline both, because public education also means that healthcare and medical education is moving towards a privatized medical system completely. So they go hand in hand. And we've seen this in the last 30 years. A lot of it, as Sarojini says, is what we had predicted. A lot of it seemed like a dystopia. It seemed like something future, but it's all here right upon us. Of course, the questions have to be asked of the state. And of course, the state has to be held accountable, and the state not only within the nation state, but whoever represents state across the globe. They all need to be held accountable for various lapses that are happening and lives that are being lost unnecessarily. But also as citizens, I think we need to learn, and we need to pause and think and look at histories to understand how we take this forward. Because as was mentioned last time by both the speakers, that epidemics soon become endemics. That it may be worse later, but we get used to it. We get used to living like this. And that used to can become really harmful for many people. So I really feel that these discussions are helping us focus more on learning for ourselves. I'm really looking forward to today's discussion. I've heard Eugene speak at the Temple University discussion and the rich panel discussion that happened after that. So I hope that we can bring some of that over here. And I really am happy to welcome Vineeta, who is a feminist comrade known for many years, a trained physician and an immunologist. And she has worked for 26 years in National Institute of Immunology and worked in diverse areas of immunology research. But more importantly, she is, and currently, I mean, she moved, as she says, moves to undergraduate teaching much later in life and sees the perils of doing that. So she's currently at the ISER, Indian Institute of Science Education and Research in Pune, which is in itself a very bold step to move from a research institute to an undergraduate teaching institute. But she's also been very active in the feminist movement, in the feminist health movement, and in the peace movement. And many of the issues that we're going to talk about today are linked to all of these. So welcome, Vineeta, and I hand it over to you now.
Thank you, Chayanika, for that introduction. And I'm really very happy I managed to listen to the first session of this series sort of halfway because of some other commitment, but I thought, I would have liked to stay until the end. So at that time, of course, I didn't know that I will be roped in for the next session. So this, of course, I'm going to attend until the end, unlike the previous one, but I'm glad that I'm here today. So I'm going to introduce Dr. Eugene Richardson. He is a physician, anthropologist, and an assistant professor of global health and social medicine at Harvard Medical School. His recent book is titled Epidemic Illusions on the Coloniality of Global Public Health, and it explores how public health practices from epidemiological modeling to outbreak containment help perpetuate global inequities. He previously served as the clinical lead for Partners in Health's Ebola response in Kono District, Sierra Leone, where he continues to conduct research on the social epidemiology of Ebola virus disease and, of course, COVID-19. More recently, he has seconded to the Africa CDC to join their COVID-19 response. His overall focus is on biosocial approaches to epidemic disease prevention, containment, and treatment in sub-Saharan Africa. As part of this effort, he's the chair of the Lancet Commission on Reparations and Redistributive Justice. Jean, welcome to this meeting, and I hand over the mic and the screen to you. Thank you.
Thank you so much. It's truly an honor to join you today. Thanks so much for inviting me, and I'm really looking forward to the discussions. I will say, and sorry to the listeners from other countries, but India is my favorite country to live in. I lived in Sarnath way back before I went to medical school. And you can see a lot of what I learned there in the book, a really relational view of the world instead of the kind of hyper-individualist view that I was brought up in. And so again, I'm looking forward to the discussion. But first, I will present some slides just to talk about the experience that led me to writing this book, and then some of the work we've done after it. Right. So it's called Epidemic Illusions on the Coloniality of Global Public Health. And this sums it up right here, that this is the Harvard Medical School shield that usually says veritas or truth, as if, these institutions in the global north somehow are the producers of knowledge to be imposed upon others. And instead, if you see this as institutions like this having a monopoly on truth, then you start to understand the coloniality of knowledge production, where views that certain ways of interpreting the world, certain ways of curating and collating data and facts come to be seen as capital T truth. But when you start to look behind the scenes, you see the kind of ideological work that these ways of organizing phenomena do. And usually it's ideological work that serve global elites. So here's the cover of the book, and this is sort of another way of saying what was said in that first image. Since Plato in Western philosophy, there was this idea of the cave where people are chained against the wall, and all they can see are the images, the shadows of these images. Here's a coronavirus. but one of them escapes. Either the social scientist or the philosopher escapes up into the top of the world and sees what the world is really like, and then comes back and says, oh, you have only been seeing illusions. This is how the world really is. And that is sort of promotes a kind of universal view of knowledge production. Whereas the cover represents a warren, or the place where rabbits live, where it's not just a cave, but there are many, many burrows. And this represents the pluriversal view of knowledge production, that there are actually many ways of interpreting social phenomena. There are many ways of curating facts. And and they all kind of vie for the forefront of our consciousness. But what happens is that some of these more subaltern ways don't have a seat at the table. They're pushed out by the places that have this monopoly on truth. And so the boroughs with the radical justice views, the socialist views, the feminist views often get pushed aside, even though they have equal interpretations to contribute, usually with a better or more egalitarian justice perspective. And this is what we would call, in the at least in the Western tradition, a pragmatist notion of truth. That truth is what we come to agree upon when it comes to social phenomena. Here, I'm not challenging things like, what we learn in physics, or what we learn as far as masks preventing transmission, or tobacco causes cancer. But when it comes to human behavior, the way we interpret social phenomena is we always come with ideological baggage, whether it's neoliberal or socialist or even more radical. But more often than not, people are unaware of this. They don't have insight into what they're bringing, the cultural imperialism they're bringing to their interpretations of phenomena. And so I use this foundation of coloniality, which was developed by South American scholars, notably Aníbal Quijano in Peru, but you could also use the neo-colonial theory developed by Kwame Nkrumah in Africa, or even post-colonial subaltern studies developed in India. Interestingly, when I talk to my Indian friends, and they say, "Oh, you're doing some new stuff in as far as radical epistemology in global health," and I say, not at all, really. These ideas were around 3,000 years ago in India, and we're just rearranging them now. And usually the aunties or their grandparents will say, "Yes, he knows where the some of the original foundations of knowledge were." And so a lot of these are not new ideas. They're just being put together in different ways. But the way coloniality is described in the South American context was that is the matrix of power relations that persistently manifests after, despite a former colony's achievement of nationhood. It attempts to capture the racial, political, economic, social, epistemological, linguistic, and gendered hierarchical orders imposed by European colonialism that transcended decolonization and continue to oppress in accordance with the needs of capital accumulation. Ramon Grossvogel, who's at Berkeley, says that the heterogeneous and multiple global structures put in place over 450 years did not evaporate with independence movements, essentially. We continue to live under the same colonial power matrix. We've just moved from global colonialism to global coloniality. And then Sabelo Ndlovu from South Africa says, despite the celebration of decolonization as a milestone in African history, Africa has not managed to free itself from epistemological colonization, inscribed on the continent and its people by mission and secular schools, schools of medicine, schools of public health, religious denominations, and other institutions that carried Western cultural imperialism. And that's essentially the project of the book, to show how what we think of as this kind of neutral, objective public health science, when operated by global North actors, actually carries much Western cultural imperialism. So just some experience that that the book was based upon, and then that came afterwards to put things in context. I worked as a clinical lead for an NGO on Ebola, and here in Sierra Leone, and here is our team, after putting on PPE, taking a patient for Ebola for isolation, testing, and treatment. Although the first place I went to in Doctors Without Borders, they weren't letting us treat patients. So if a patient came in with shock, viral hemorrhagic fever with shock, they wouldn't let us put in IVs. And there was talk about, well, it's unsafe for the patients, unsafe for us. But really, it carried on this, colonial practice, which Paul Farmer explores well in his new book, Fevers, Feuds, and Diamonds, of a containment over care paradigm. That there's, ever since smallpox and malaria outbreaks, in the past, where the idea was just to isolate people so that things wouldn't spread, but never to really deliver the care that was available, the antibiotics and other things that were available, has carried on to the present day. And Chayanika also spoke about that, how, it's even present in contemporary India. Here is a similar, a parallel with a COVID patient in Boston. Here is what burials looked like in Sierra Leone, and they were an important part of containment. But here's what, this is the back of a hospital in New York during the COVID outbreak. So people were dying so much last spring that they had to bring refrigerated trucks to start piling the bodies on. And so, part of this imagery is to kind of blur the boundaries between these ideas of first and third world countries. Before the outbreak, or before the pandemic, there was a report, I think somewhere from Hopkins, on global pandemic preparedness, and the USA was #1 in it, even though we have one of the worst outbreaks right now, and that's reflected in these pictures. Here is a graveyard outside an Ebola unit in Sierra Leone, but here's a mass grave in New York City. So for patients last spring that weren't claimed by family, they were digging mass graves. I mean, this is the reality of the pandemic in the richest country in the planet. Here we are in Sierra Leone doing community sensitization with the military, and going house to house to do contact tracing and active case searching. Here is an Ebola treatment unit. But here in Boston, where I work at a hospital, is our convention center that had to be converted to a COVID hospital because all the beds were filling up. So I talked about my experience in Sierra Leone in 2014 and 15 in that Ebola outbreak, and then I had worked for the WHO in the outbreak in the Democratic Republic of Congo. So what changed over 4 years? How what impressive advances were made in Ebola in the realm of medicine. So actually a vaccine was developed. I talk about in the book how there was a lot of vaccine avoidance as there is the current COVID pandemic in Congo. And there was a Harvard School of Public Health study that explained, well, there's vaccine hesitancy, there's a huge outbreak, because people believe in misinformation. So essentially they have their ignorance to blame for it. If only, they would read the pamphlets and listen to the WhatsApp groups and all of that, then we wouldn't have such a big outbreak. And that really, to me, that enforces Western cultural hegemony, a neoliberal view that individual actors are the prime determinants of what happens with health phenomena. When you start talking to the people and you start looking at things, socio-historically, you find that people in DRC, it's not lost upon them at all that their ancestors had their hands cut off by King Leopold from Belgium when not enough rubber was gathered, and all the colonial extraction that took place during the Belgian colonization. And then the US and Belgium colluding in the assassination of the first prime minister, and Patrice Lumumba. And then the US installation of Mobutu as a Cold War puppet dictator, where they just paid, we just paid him a little bit to reign from Kinshasa, while our corporations, took the riches from the ground in Eastern Congo. And Congo is a very rich country, although you would never know it by being there, because of this extraction that continues to this day. And so this is not lost upon them, this history of extraction. And so if you see this kind of disbelief, this hesitancy as a historical consciousness, as a structured disposition towards eluding depredation that has occurred every time a foreigner has stepped on the soil, then you start to understand that the intervention is actually not more aid or WhatsApp groups or knowledge, action, and behavior programs, but that it is reparative justice. That, for example, when they would ask me, what do you think we should do to get people to take vaccines? And I'd say something like, let us pay each person $500 and get $100 million from Belgium to do this. And that $100 million will be the first installment of a several $1 trillion reparations plan to pay back what was stolen. And I'd get laughed out of the room. But it is a serious issue. I'm the chair of the Lancet Commission on Reparations and Redistributive Justice. We have a section working on Congo, and they are totaling up how many trillions it is, and we'll be making recommendations on that this summer. I had invited a colleague, Utsa Patnaik from India. She totaled up that the UK stole at least $45 trillion from India during colonization. So, if reparative justice had been served, I don't think we'd be having this conversation today about, India's pandemic preparedness. It would be on a completely different level if such extraction had not taken place. And so that's also part of what I talk about in the book, is how, not only how models and regressions and all that stuff can do imperial and racist work, but also that if the interventions move from this paradigm of aid and development to actual reparative justice, that a lot of the things we're talking about, these underdeveloped health systems, wouldn't even exist in the first place. Here's an example as far as the COVID vaccines, of coloniality rearing its head. Back in April of last year, there were French doctors who said publicly, with no shame, let's test the vaccines in Africa, because they're not going to wear masks, they're not going to social distance, the force of infection will be higher, and therefore we can get our answers quicker. There's coloniality rearing its head on the economic front. So when I was first seconded to the Africa CDC in August of last year, they said to me, can you help with procurement of tests and PPE? I said, well, I'm an infectious disease doctor, not really a logistician. They said, yeah, but this is the most important thing. We have the money to get these resources, but we are being outbid and outmaneuvered by the old boy network of global North countries. And it's not just that they were being outmaneuvered because there were limited supplies, as you see right now with the vaccine. What we're calling vaccine apartheid right now is an example of rich countries hoarding excess amounts of vaccines. So the US has 5 times the number of vaccines per capita. Canada has 9 times the number of vaccines per capita, whereas as of a week or two ago, 130 countries in the global south hadn't even vaccinated a single person. And so this is an another example of coloniality of not only resource management, but also knowledge protection. So the US likes to fancy itself as having developed this, and even Europe, where vaccines were produced, as having developed this intellectual property that they want to protect for the profits of big pharma. Yet, if you continue to look historically, that these advances are made based on the wealth and advanced, step-by-step advances that were created from colonial extraction and continued neo-colonial extraction, then you see that this vaccine apartheid is not only immoral, but farcical. And so there is a big movement right now for waiving the intellectual property rights. And I would say this should not be seen as some sort of savior mechanism or savior behavior from the global north, but rather what's described right here, that descendants of colonialists, I think and this is, the social scientists and epidemiologists in the global north I'm talking about, they and aid workers and development workers, I think they often see themselves, their moral relation with the global south, as being one of these saviors. Like we worked hard to get our resources and now we're in a position to share them. But if instead you understand historically that the global north is actually a beneficiary from and a supporter of a global institutional order that continues to systematize the oppression that was laid out during colonialism, what we would call coloniality, then again, the interventions look different. They are no longer this aid and development paradigm, but they are reparative justice. I mean, imagine UK trying to pay the 45 trillion that they owe India. It would take centuries. It's many times their GDP, but it is something that I think needs to happen and is coming. And what I'm most interested in is essentially the coloniality of perception. How certain views are seen, rise to the level of truth and then are imposed upon people. So for example, of, saying that the outbreak was big in DRC and people weren't getting vaccines because of their ignorance, that narrative took hold. So the WHO, the Ministry of Health there, even started saying, oh, if we could only, prevent these mistruths, if we could only, make the WhatsApp groups better and make the pamphlets better and get more chiefs on board, then we'd stop this outbreak. Instead of looking at, if you see, and this actually that way is imposed upon people. So, they're told that this has to do with their, lack of understanding of virology and not the actually sophisticated critique that they're making of legacies of colonialism. And so this is what I'm talking about with the warrant, that view of a critique of colonialism, that mistrust because of histories of depredation doesn't have the seat at the table. The one that says they're ignorant, that there's no reason to pay reparations, there's only reason to just give a little bit more aid, that's the one that takes center stage and achieves cultural hegemony. And that way of running the world does support, the global North countries. And Kwame Nkrumah back in the 1960s was saying that aid is just a revolving door where a little bit of money is given to hide, to disguise the huge amount that's being taken with the right. And the slide I like to set, or the figure I like to cite for this comes from a 2017 report on Africa from Jubilee and others, basically showing that in that year, $140 billion came into the continent of Africa in the form of aid, loans and remittances. And $200 billion came out in illicit financial flows, so illegal flows, resource theft, tax evasion, and trade misinvoicing. So the continent is a net creditor to the global north of $40 billion. And what that to me means is that development is actually a total farce. We have our U.S. Agency for International Development, which people think is taking excess resources from the north and helping develop the south. But if they continue per year, the continent alone of Africa to be a net creditor for the net flow is that way of $40 billion, then again, development is a farce, and really this extractive relationship continues to this day. It's just better disguised. And that's why I would say things like the Panama Papers, that sort of started digging into how these global North corporations, avoid taxes, hide money in shell companies, do their resource theft. Those to me are some of the most important interventions in the global health that we have. And so that's moving, the needle from just, the sharing of medicines to actually exposing how illicit financial flows work. So another foundation for the book is the care knowing, and this is one of my favorite works from Vineeta Bal, Caring to Know, Comparative Care Ethics, Feminist Epistemology, and the Mahabharata. She says that care knowing is an approach to social inquiry where care as disposition and avoidance of injustice have epistemic significance beyond regulating knowing encounters between individuals. So in other words, and the reason I'm showing this is because the Ebola interventions did evolve from what I talked about at MSF, where we weren't allowed to even put in IVs, to in Congo we actually had these Ebola cubes, and this was an obstetric unit where infected pregnant women with Ebola could have C-sections. So care became a more important part of the response. But care knowing basically says that if we're looking at interpreting social phenomena as in a pragmatist fashion, essentially it's what we come to agree upon, and right now the dominant way of seeing things serves neoliberal interests. That if we actually take as a start for how we curate facts, how we interpret social phenomena, avoidance of injustice, so eyes towards reparative justice, then the way you will present, collate your data, curate your facts, actually turns out very differently. And I'm going to give an example of some anti-racist modeling we did for COVID, which essentially provides an example of this, and an example for which we have received a lot of hate mail, but I'll get to that. And then to comment quickly on the positionality I take, here I am, this, a white man from Harvard, talking about colonialism. And so, my goal is not to talk about what the experience of oppression is like, because I obviously don't know that. But I do see how the harmers do their harm, because I have worked at the WHO and the World Bank and various NGOs and the CDC and institutions like Harvard and Stanford. And so I have a firsthand look at how the oppression is generated, how harmers do their harm, how the categories are forged that serve elite interest. And so that my goal is to comment on that. Right. I talked about cultural hegemony. It's another important foundation in the book, that, if exploitative socioeconomic relations are indeed foundational to the social order, as they are inside the US and as they are between the global North and global South, then it's likely to have a fundamental shaping effect on social ideation. Meaning that if this is the way the system works, then it's likely to filter into, again, these things we call social science. I also use the term bourgeois empiricism and define it as that, models of disease causation that obscure socio-historical forces. So the model of disease causation that says Congolese people are ignorant, that is a political act that gives support to social structures that hide behind scientific objectivity to perpetuate dependency, exploitation, racism, elitism, and colonialism. And then the way this is recycled is that, the article that says that, people have their ignorance to blame gets in the Lancet. And, the article that I wrote about how it's sort of a historical consciousness got in medicine, anthropology, and theory, which, the readership is orders of magnitude different. And so, it's built into our interpretations, it's built into the peer review process, as I found with this anti-racism modeling paper. It's built into what journals, will accept the final, radical or non-radical article. So at any level, you can find coloniality at work. In the book, I also trace how in the DRC where I was working, to trace the sort of economic foundations of the current extractive model there, I looked at Anglo-Gold Ashanti, which in nearby Tanzania, when they do their mining there, take about 93% of the wealth out of the ground to the global north. And so something similar is happening in Congo. You can see why that there's underdeveloped health systems, because the level of extraction continues until this day. And it goes to companies where, so Anglo-Gold Ashanti, the lead shareholder is John Paulson. At Harvard, the School of Engineering is the Paulson School of Engineering, named after him because he donated $400 million to the country, or to the university. And so you can see just from Kivu all the way to our door at Harvard how this extractive network works. And so Harvard serves as sort of the laundering of the reputation of people that are doing that extraction. So there's collusion across the network in again, what is a continued extractive model. I also use this term symbolic violence, and it's just another way of saying that this capacity to impose the means for understanding social phenomena by representing the economic and political world in disguised, taken for granted forms. And here's a paper we wrote on symbolic violence in the Ebola outbreak in Sierra Leone. I also use this technique called détournement, which is from the French for hijacking. And this is, 50 years ago, they were doing things like this, where you would take advertisements and rearrange them to make radical messages. And so I took this Ebola poster from Sierra Leone, which basically says, if you have these symptoms, go to this health center. And to me, what this poster represents is that, there is this thing called Ebola, and it causes this sickness, and you can get better if you go to this health center. But really, I see Ebola just as a marker, just as the tip of a long determinative web of, that begins with colonial relations, moves into the post-colony and neocolonialism, that is represented by, epistemic violence committed by global North institutions, by structurally adjusting in the name of economic growth by IMF and World Bank, by the Holocaust of slavery, by the barbaric colonialism I described earlier, by purposeful underdevelopment. And then here is that figure I was talking about, illicit financial flows. These all lead to a underdeveloped health center, which has no way of containing Ebola. What we did show in Sierra Leone is that if just the taxes on the diamonds that have been mined and essentially thefted had been paid, the health infrastructure would have been strong enough to prevent Ebola. So really tracing the historical structural determinants of these outbreaks, instead of blaming them on this individual, calling him a super spreader, which I'll show a few slides on, the symbolic violence that that commits. And so I'm hoping that our social scientists and epidemiologists will then see themselves not as people that are trying to get this capital T truth, but rather ones that struggle against forms of power where they are both objects and instruments. And so I'll pick on the mathematical models of infectious disease transmission in the last few slides. I see them not as a form of outbreak science, which is what they're called in the US, but merely fables that are dressed in formal language and give the illusion of being scientific. And I say that because, our future is socially constructed. So any forecast you give is something that is trying to gather the social imaginary so that we can arrive at a better place. But oftentimes the social imaginary is delimited in ways that support status quo relations of inequality. And I think for the most part, these models serve not as forecasts, but means of setting confines to the understanding of why some groups live sicker lives than others, confines that sustain predatory accumulation rather than challenge it. And this essentially serves as the afterword of the book, but it also exists as a commentary in BMJ Global Health. Here I'm bringing up the symbolic violence of super spreading, or using the term super spreading. So this is an article from the Proceeding of the National Academy of Sciences, Spatial and Temporal Dynamics of Super Spreading Events in the 2014-2015 West Africa Ebola Epidemic. And in this article, they use the term super spreader 38 times. And the news media picked up on it and interviewed the authors. And this is essentially the finding from the study. This is the narrative that spread, that super spreaders drove the Ebola epidemic. This is the super spreader. And if only, and they conclude, if only we could notify or identify these people early on, that we could stop the outbreak. And to me, you know, as a critical theorist, you know, you want to interrogate that category. Is this person a super spreader? Are they an Ebola patient? If you use a relational model instead of an individual model, you would say that they are actually just a personal protective equipment bereft care nexus. But what you know, to me, this does neoliberal work, blaming super spreading on this victim of Ebola. If you would look at the diamond mining company that, again, engaged in all those illicit financial flows over the past 100 years in Kono district, set the stage for this Ebola outbreak because of the money that could have been used for health infrastructure, then the mining company is the super spreader. It's just you're looking back a little further in time. And so what is it about how we create categories in social science make it such that we call him, this victim, a super spreader instead of the mining company? And I think it has a lot to do with how, you know, the corporate interests, neoliberal interests, this focus on the individual is perpetuated instead of looking at the structural and socioeconomic determinants. And to me, that is how this words like super spreader commit symbolic violence. So I obviously see epidemiology as a dispositif, or as an apparatus. This is a Gamben's extension of Foucault, that an apparatus is literally anything that has in some way the capacity to capture, orient, determine, intercept, model, control, or secure the gestures, behaviors, opinions, or discourses of living beings. And this is something that infectious disease models do. They capture our attention, they orient us to where we might be heading with a pandemic, they determine behaviors with their recommendations, and they kind of mark the discourse that we use. And so here I'm going to just give an example of the COVID modeling done by the Institute for Health Metrics and Evaluation at the University of Washington, which has received over $600 million from the Bill Gates Foundation. And here's a good article in The Nation. You know, do these hundreds of millions distort public health data? And you know, the answer to me is yes, because again, they do things like reify the word super spreader as this bounded agent of spread, an individual, instead of looking at how global north extraction is the real pathology, is the real super spreading agent. As far as their COVID forecasts are concerned, they were wrong, first of all. So their next day deaths, their predictions fell outside of their 95% confidence intervals as much as 70% of the time. So they're completely wrong. But their low and plunging projections were also used by Trump to say that he was doing a good job. So they are easily co-opted for ideological purposes. But I would also argue that they do racist work, because essentially, if their only intervention is masks and social distancing, then yes, we might go from a million to 500,000 deaths through this intervention. But right now in the U.S., we have as much as 3 times the incidence of mortality among Black people. There's this disparity that is structurally determined, and so if there's no intervention into that disparity, then the status quo disparity continues. So, 1 million people die, but still 3 times the number of Black people, or 500,000 people die, but still 3 times the number of Black people. Then by Ibram Kendi's definition of racism, that a racist policy or analysis is one that either furthers inequities or continues status quo, then these are racist because they envision a future where status quo disparities in mortality continue to exist. Institutionalized racism continues to exist. Hyper-incarceration continues to exist, and universal health coverage is denied. So in short, they actively delimit, through their exaggerated precision and acceptance of government interventions as status quo, the public's ability to imagine social alternatives. So to imagine social alternatives, we formed this Lancet Commission on Reparations and Redistributive Justice. I will say that Sukadeo Thorat from the Institute for Dalit Studies in India is leading the India section, and his team is working on reparations for caste in India. So not even a global North, global South, but an intra-India phenomena. But you know, one of our ancillary papers to show what anti-racist modeling might look like just came out last month in Social Science and Medicine, entitled Reparations for American Descendants of Persons Enslaved in the US and Their Potential Impact on SARS-CoV-2 Transmission. So Dr. Darity has calculated that the wealth gap between Black and white Americans in the US is $10 trillion. And that is seen as a legacy of slavery, Jim Crow, hyperincarceration, lethal policing, redlining, unfair credit markets, all of that. And if that were eradicated, if the 40 million descendants of people enslaved in the US were paid the 10 trillion, so it's $250,000 per person, say 10 years ago, we calculated that SARS transmission or COVID transmission in the US would have been 30 to 60% less across races. And because of the way transmission dynamics work, you know, they're usually, the group is determined by the smaller, highest risk group. And so if there's an intervention in the high risk group, it's actually benefits the population at large. This made it into CNN and whatnot, and we received loads of hate mail. I could see the cultural wars at work, and it's something we can talk about. But I'd like to end there. Thank you for listening. Here's my email if there's any further discussion afterwards, but I look forward to the rest of the seminar.
Thank you, Jean. Vineeta?
Thank you. Jean has provided us with an excellent canvas of epidemics from not just various parts of the world where all he has worked, from Congo to other areas, including New York, but he has also extremely highlighted the persistence of colonial perspective, which not just persists, but creates problems in seeking reparative justice. And I was also amused, Jean, by your comments on mathematical models and super spreaders. Enjoyed the talk. Thank you. So with that, I will probably move a little bit away and focus on what we see as more local issues. They are not necessarily only present issues, but present and past issues. Partly because neither Ebola nor Zika, which Sama and the others were interested in highlighting, they have made a serious impact on the subcontinent. But the subcontinent has seen very many waves of infectious disease outbreaks, some reaching huge proportions and of course some not. I came across a recent review which listed epidemics and pandemics in India, and I realized there is a lot to learn from these episodes in India too. So I also, as I had mentioned earlier, I was present for Professor Kidambi's talk when he talked about plague, but obviously today we are going much beyond that. Let me just put up a slide which I'm going to share. So I'm going to talk about major infectious disease outbreaks in India on the backdrop of what we are experiencing over the past year. I'm not sure how complete this list is. The reference for this has been given below. It's a August 2019 review, but I'm sure it is not listing small outbreaks of diseases, and only major outbreaks have been mentioned, and possibly even some of the significant outbreaks have also been missing from the list. But when I was looking at it, I started thinking along various aspects, and I thought maybe I should talk about that. So in the 19th century, there were two types of outbreaks. One was of one category was cholera, the other was plague. And as you will notice, these are the years in which cholera outbreaks or cholera epidemics were recorded. So there were 6 epidemics of cholera and only 1 of plague. In the 20th century, so what you see here in the 19th century, let me just talk about that both of these, cholera and plague, are bacterial diseases. And there were no viral disease epidemics recorded. And looking at the time when these were recorded, I wondered whether the technological challenges, such as identifying viruses, were partly responsible for some outbreaks not getting a mention, not getting listed. So they might have simply disappeared without leaving a trace in history, unless we go back and look at the maybe colonial records, if I can call that, and find out something more about it. So when we now look at the 20th century, the influenza pandemic is something that all of us have heard really, really extensively. And that started immediately after the First World War, and it affected India also very badly. In addition to that, and this is partly chronological listing, there was polio, there are smallpox, and also plague. So out of these which are listed, there were, so polio apparently spread for many years. And after that, major polio prevention campaign, as in oral polio vaccine, started. Smallpox in 1974-75, India was declared free of smallpox, if I remember right. But maybe before that, there were patches of smallpox, and it deserved to be called as an epidemic. And plague, of course. And what you will notice is these are essentially viral infections which dominated the scene. Certainly, cholera did not show up on any significant scale as it did in the 19th century. So what might be the reasons for near complete absence of cholera epidemic in India in the 20th century? Does one give credit to improvement in sanitation, improved awareness, and so on? Or should vaccination efforts, which accompanied major religious events such as Kumbh Mela, be given credit? Currently, Kumbh Mela is on, so I can't help mentioning this again. Of course, Kumbh Melas have been taking place every 12 years or whenever they are. Or is it the case that there were many small episodes of choleras, but with a combination of these and some of the other controlling factors, none of those episodes reached a scale where they could be listed as major outbreaks or epidemics? The question is important from public health perspective as well, because it will help in documentation of disease histories. The only thing I can say with a significant authority is that the vaccines played pretty much no role beyond psychological satisfaction to the people in power for the cholera epidemics, or control or absence of cholera epidemics, because cholera vaccines were pretty much useless. So let's move to the 21st century now. We have only completed 20 years of this century, but the list is quite long. It's the longest of all. So the last one, SARS-CoV-2, obviously is not mentioned in the epidemic. In the review, I have listed it because, as I said, the review was published in 2019. So in the last, as I said, there are 10 outbreaks or epidemics which have been listed here. This is a high number. And 8 out of 10 are viral diseases. So meningococcal meningitis is there, and plague. Those two are the exceptions. Otherwise, every one is a viral disease. There are many points which sort of emerge from this interesting information. Should an increase in frequency be of serious concern? I think it should be. And is it simply due to a better reporting system, or are the epidemics really increasing? Is high population growth, invasion and destruction of wild terrain contributing to zoonotic diseases like COVID-19 contributing to this high frequency? And as I mentioned, epidemics of bacterial origin are relatively few as compared to viral infections. And one possible reason that one can put forward is that there are now reliable antibacterial antibiotics available for treatment, but such medications are extremely uncommon, very uncommon for the viruses. Hence, possibly it's harder to control viral diseases. I'm sure there are more reasons than just what I've listed, and they are of diverse nature, such as poverty, hygiene, sociocultural norms, ecological destruction, global warming. Apart from a study, apart from a neglect that we have been seeing by the Indian government to strengthen the public healthcare system. This Sarojini also mentioned in her introductory remarks, all of us are, who are attending this session, I'm sure are very well aware. But still, I thought, since we are talking about public healthcare system, let me just mention what is available or what is quote unquote functional as a formal structure or as formal structures in India to anticipate and handle epidemics. So there is something called National Center for Disease Control. This is located in Delhi. It is under the Ministry of Health and Family Welfare. It's a key institution in the epidemic context. While it is supposed to have expertise and authority to provide inputs in predicting, investigating, and managing epidemics, as we know in many other institutions of repute, quote unquote repute, even in India, this institution is also falling short on manpower, expertise, and authority. There is a second institute which is called IND-CEPI, C-E-P-I. This is an IND-CEPI mission that is India-centric epidemic preparedness. That's how the full form is. And it was launched in March 2019. This mission was launched in March 2019, and it aims, as is mentioned on their website, to strengthen the development of vaccines for the diseases of epidemic potential in India, as well as build coordinated preparedness in the Indian public health system and vaccine industry to address existing and emergent infectious threats in India. So it is sort of, comprehensive way of putting forward how the system should be. But unfortunately, this INCEPI is so new in itself that in 2 years period, 1 year is of COVID-19 pandemic. So there isn't too much to talk about what it has achieved and what it has not achieved. However, it comes under the Department of Biotechnology, under the Ministry of Science and Technology. So 2 institutions in 2 different ministries of the government. And the INCEPI is supposed to be helping in development of new vaccines, developing strengthening infrastructure, supporting in capacity building, strengthening inter-ministries coordination, and so on and so forth. And this interministerial coordination is something that I wanted to comment on, because it can be an advantage and it can be a disadvantage. As it happens, both NCDC as well as INCEPI have overlapping thrust areas. So there can be an advantage because 2 institutions with different spread can actually work together, but there can also be a disadvantage, especially if the ministries, parent ministries and the people in the 2 institutions are not on talking terms. So what one can visualize is that while promoting vaccine development is certainly a mandate for Department of Biotechnology, Disease-related investigations, epidemiology, surveillance, etc., fall under the health ministry. So they are actually complementary also partly to in their approaches. But how efficiently or cooperatively and how knowledgeably various arms of the government are working is a question that many of us are asking. We see the failures, but we still need to ask the questions, because ultimately we do need to get some improvement despite resisting all the state repression and many other activities that we continue to do so. One other problem that I would like to highlight, and this is again a major problem that remains unaddressed, that is poor data. Poor data in terms of health indices, disease prevalence for infectious and non-infectious diseases, vaccination status, and so on. Government after government has neglected investing in strengthening data collection exercise. Since policy decisions are to be based on available data, and since solid data are prominent by their absence in this country, many decisions are taken which are of poor quality, and it's not surprising that many policies do not succeed. Let me, in the end, sort of make reference to the current pandemic briefly. It's hard to define how many deaths, for example, are primary deaths and how many are secondary deaths in this pandemic, which means that where COVID-19 was directly responsible for the death, or it was a coincidental event for the death. There are in principle actually guidelines, but not enough trained people to implement it, not enough outreach into small places throughout the country. As a result, the clarity between the primary and secondary deaths remains really vague. Pandemic and initially poorly planned prolonged lockdown, as we know about, which was implemented a year ago, and many of us again are in the situation of massive pandemic, massive lockdown. Last year's lockdown pushed many people in India below the poverty line. Job losses, hunger, poverty, malnutrition all led to massive debts as well as deaths. Almost all of them were secondary deaths, possibly not causally related to COVID-19. Will they simply add to poor reporting and incomplete classification of data? Will such a record teach us anything about public health in the future? And an interesting part of COVID-19 morbidity, and this was just a footnote that I wanted to add and stop there, that morbidity and mortality in COVID-19, as based on the statistics from the developed countries, has reported that women are better off than men in terms of both morbidity and mortality. They suffer less, they die less often. Will we see in the poor, undernourished women in India the same pattern, or are they likely to be different? So will female hormones provide tenacity to face illness even when women are horribly undernourished, and how horribly they were pushed to undernourishment over the past 1 year because of job losses and because of various aspects, social problems that we have seen? I think I'll stop there. I know I was probably going a little beyond the time permitted, but thank you very much. So first question is from Shivanand Savatagi. I'm Shivanand. We always talk about self-reliance, why people are still irresponsible. Enough information is flowing around, helping hands are there, but still I see people ignoring things. When we talk of self-reliance, whom are we targeting? Is it for people or government, policymakers, experts? Any thoughts? And what I've seen is most of the questions are for Jean, so I'm very happy. I don't have to answer anything. You can go ahead. Start with this if you can.
So maybe I'll just give the example from the US, where, there's also this phenomenon of information flowing, but distrust of vaccines and people, not wearing their masks. And so I often look at structural determinants of why people behave in the way they do. They may receive perfect information that the mask prevents transmission, that the vaccine will prevent mortality, but they don't take it for in the presentation I talked about in DRC, this historical consciousness of eluding or of depredation. But in the US, I think it's actually the complete opposite. I think there is this, or at least among some of the white populations, that is more this habitus or this structured disposition towards entitlement. That there are these groups that they see their privilege being eroded as the country diversifies, and their response is not to embrace the coming equality or egalitarian movements. It is to actually lash out against what they see as an erosion of their status. And they don't look at it as the privilege that has been accumulated through centuries of oppression. And so the structured response is to lash out against it, is to disregard the information and to sort of act against the recommendations. And so I think that the problem is not one of the information not being out there, but one of unequal societies, that you really can't act on. I think I've come to believe that you can't really act on information in very inegalitarian societies. So you see in like Taiwan or Japan, they actually do pretty well to act on it. India, Russia, South Africa, Brazil, the US, the most unequal countries are the ones that you see this. I mean, and it doesn't hold across the board, but I think there is something to the nature of an inegalitarian polity, and the competition, the jealousy, the lashing against when people are mobile in different directions economically. That is actually determines people's behavior, and not the actual logical response to the information.
The next one is by Nikhil Pandey, and the question he's asking about, I was wondering, how does the question of responsibility get implemented in the discussion of coloniality and reparations? And I'll also join with the second half of the question. How might an overemphasis on reparative justice draw ethical and political attention away from everyday acts of post-colonial states that promote a containment over care paradigm, and specifically, in the case of India, the role of distinctive structures like caste, for example, that have pre-colonial genealogies? This is obviously a student of anthropology throwing a question at an anthropologist. I was running out of my breath to complete the sentence, but it's all to Eugene.
All right, thank you. Yeah, that's a great question, and that shows first the limits of using a term like coloniality, because it does not apply across the board, right? For caste relations, or even my Black colleagues in the U.S., they would say we're not colonized, our ancestors were enslaved. And so I start out with the admission that it does not encompass all the forms of oppression that are out there. And we even ran into it when I was writing the introduction for our Lancet report, and I couldn't include Sukadeva Torat's work under my coloniality paragraph, because again, the structures were pre-colonial, but they're similar. The way I wanted to describe it, which everyone vetoed, was from the phenomenology literature of life worlds. So it's people's life worlds are colonized. So you could say caste in India, they have colonized the life world of lower caste. I've even heard women in Democratic Republic of Congo say to me, it is the men that colonize us, which again is not, is using the term of just how, oppression works. But I think getting the symbols and the semiotics and the terminology right is important. I'm joining another panel in Geneva where one of the questions is decolonizing even the right term? And they're talking about humanitarian work. And one of our colleagues from New Zealand, who is Maori, said, yes, it shouldn't be someone like Eugene who's discussing it, right? It should be the people that are actually experiencing the oppression, and I agreed. And she mentioned, we could say something, instead of decolonizing humanitarian work, we could talk about indigenizing it. And so, yes, there are different, I think it's important to, when people start, when there are more people at the table, more people discussing, like how we actually change our categories, because certain categories do more, all categories do ideological work, but can we get to ones that do more work as far as justice is concerned? And that is actually, again, pragmatism, critical pragmatism in a nutshell, that there is no final vocabulary for describing the phenomena around us, that we're always looking for better ways of redescribing phenomena, more just ways of describing them. And then as far as the question of responsibility, yeah, that one is difficult. I mean, we're already looking at, just a few days ago in the US, it was the first time the HR 40, which is a House resolution to form a committee on studying reparations, has been discussed, and it's been around for 20 years in the US. And already you could see the culture wars starting, and people saying, I'm not responsible for what people did 200 years ago, not understanding that their current privilege is based on the building up, the foundation to the current day. And so I think for me, and there's lots of ways to approach this. There's grassroots Black Lives Matter movements. What I see myself as doing is trying to jostle the purview of colleagues at schools of public health and schools of medicine, when I think we've all been co-opted into putting out categories, putting out work that continues these status quo relations. How can we decenter? How can we kind of dissemble? How can we shake things up such that people whose job it is to work on the health of populations actually work towards equity instead of perpetuating status quo relations of inequity?
Thanks. The next question is by Abha Rao. She would like to know more about your views on AstraZeneca and J&J vaccine being withdrawn in Europe and US, while there are few alternatives in Africa.
Okay, great question. And mine is going to, I think, be a radical view on this. I actually think that because we have, and I have never said this before, but I'm happy to say it now, that now that, we actually, the mRNA vaccines are a little bit better as far as at least, protection, and there's not this evidence, very small evidence of clots. We're at the point right now where we don't have good enough manufacturing centers for the mRNA vaccine. We could have done this a year ago. We could have dissolved the intellectual property on it and started a movement towards building these mRNA vaccine production centers, which is already starting now. I saw the Africa CDC had a conference this week where that is the goal, to produce mRNA vaccine centers, which may help us in this pandemic, but will help us in future ones, because mRNA is great in that, you can develop it in a week, once you sequence it. And so for a changing pandemic, you can change things quickly. The problem is the freezing. But I think if we thought about this earlier, and there was no intellectual property problems, that everywhere with vaccine capacity making could just make the best ones. But instead, what we have is that we want Johnson & Johnson and AstraZeneca to get their profit. So we allow them, we continue the situation where they'll make a vaccine that is slightly inferior, and especially for certain variants, AstraZeneca is showing inferiority. And so we're not doing as good a job of containment because we're focusing on profit. An ideal system to me would be AstraZeneca and Johnson & Johnson, we see that theirs are a bit inferior, that they just take over producing mRNA and they're paid for doing it, because that would allow for sort of the best vaccines to circulate. But now we're in the situation where they're already producing it, they're getting their profits. And so so we have to handle the current situation we have, which is, I think it's important because they were fast tracked so quickly to walk back and see that they are safe. But I also think we may find that, COVID itself causes much more, thromboembolism than the vaccines do. I think we're going to find that even like the oral contraceptive pill does. And so we have to, even though there's the signal, we have to weigh, risk over benefit. And right now, the benefits of the vaccines far outweigh any of these small risks shown. But I'm hoping in the future, the situation will be set up that intellectual property is waived for pandemics, and all vaccine centers can take over manufacturing the best ones instead of letting people run with the one they've already decided on months ago to maximize their profits. So
there are quite a few questions, Gene. You are a very popular speaker, but I will have to use some discretion. And just now I'm putting Farida's question to you, and then I'll probably move to chat box and come back. We'll see how I can adjust the time and questions, give justice to both people who are in the question answer area as well as chat box. So Farida has asked, how is industrial food production, genetic modifications, and destruction of natural food source can be a cause of virus like coronavirus?
Yeah, I mean, so that's not my expertise, and it does raise the issue that the responses and the understanding of these phenomena have to be multidisciplinary. In fact, in the book, I talk about superdisciplinary. To me, multidisciplinary means people still maintain the bounds of their discipline. They still only publish in the journals which are going to get them career advancement. I think that we have to, move beyond that, where we have teams working together with expertise in all of these areas. For me, I think one of the important things about the emergence of viruses like this are the farming practices and the animal practices, where, same with flu, when you have huge pig farms in association with big bird farms, there is the chance for the reassortment to occur that could lead to future flu pandemics. And the same thing, I think, with animal farming practices led to coronavirus. And so that is something that needs to be either regulated or worked on. But again, that's not my area of expertise.
There was one question from Mohan Rao, which I'm asking: why is there no discussion on compulsory licensing in India to get public sector institutions to manufacture vaccines?
Yeah, I mean, that is, so, India and South Africa brought up the TRIPS waiver in September, and they brought it up again. And this is coloniality at work. There's the pushback to prioritize big pharma profits over people. I saw just this week, 170 Nobel laureates and heads of state signed a letter to Biden about supporting the TRIPS waiver and releasing intellectual property. But I think that has to be, this should have been done a year ago, and it needs to be done for all future pandemics, that the manufacturing, medical manufacturing might of places like India and South Africa is allowed to, produce what we need for containment, because that is the huge problem right now. We don't have enough vaccines, and we don't have enough vaccines because of the prioritization of intellectual property and profits. And so, yes, I support it, and hopefully at the next WTO meeting, there'll be enough push to waive it, and that'll help a little for this pandemic, but for future, it should hopefully set the precedent.
The next question from the chat box is by Raunak. How can we address the inaccurate memorization of past pandemics compared to global wars, especially in early academic history curriculum? Would love to know your thoughts. Inadequate memorization rather than inaccurate, sorry, inadequate memorization. Both are correct, actually, inadequate as well as inaccurate, but Jean, you can choose to answer whichever you think is better.
Yeah, I mean, and so that to me, it's very important. Some people will talk about, you should, like the materialists would say, we should only focus on material deprivation and resources and, things economic. But I personally agree that the symbolic realm is very important, like how certain histories are whitewashed, how certain histories are told are important, because that's really what determines, that's what structures people's behavior. And so, my effort was to shake things up in the public health world as far as representing phenomena in ways that have an eye towards justice instead of status quo relations. But I think it's the goal of all of the scholars and teachers that it's not just the public health scientists that have an important role in this. It's the people working in literature and all of that, creating the categories, the symbols, the narratives that to go back to Dalmia, that start with a care knowing, that an epistemology that tries to avoid injustice with how it is creating categories, with how it is, creating narratives.
Okay. The next question is by Nirmalya Syam. I'm interested to know the views of Eugene on the idea of a pandemic treaty that is gaining traction of late. It appears to be very Eurocentric conceptually, but some developing countries have joined a call issued by world leaders recently. Do you see any potential concern for the South with S capital, in such a treaty mechanism?
So I haven't been following as much this pandemic treaty because we've been writing an article more on COVAX. And so I'll speak to that one since I don't have the details to speak on this one. But, COVAX was supposed to be this, global institution for providing vaccines, getting equity in vaccine distribution. But essentially, it's been handcuffed by bilateral negotiations and global north countries buying up all the vaccines, so that there was very little for COVAX to even purchase and distribute. But I think it also has played a role in obscuring the role of intellectual property. The goal of COVAX was not to waive intellectual property so that places like India could manufacture vaccines. The goal was just to continue in intellectual property so that global north countries could continue to do this charity model of paying for vaccines that don't exist because the manufacturing has been hampered. So I don't know if it has that in it, but I think even what was considered the best example of like a COVID equity plan can be shown to have imperial machinations built into it.
There is a note which is disagreeing with in the chat box, disagreeing with what you said, saying, this is from Hard Wolskin, you haven't addressed racial capitalism, which is the root cause of coloniality and extraction, and also haven't referred to the capitalist destruction of natural habitat for industrial agriculture and meat production, which is the probable cause of both Ebola and COVID-19 epidemics. That is, yeah. So you also didn't refer to racial capitalism as the source of intellectual property, as a barrier to care, for instance, with vaccines. Why? Will reparations and other reforms achieve the goals we seek without moving beyond racial capitalism itself?
So great question. So again, it goes back to this, how we describe things. And so I think by talking about a system of coloniality, a colonial matrix of power, I was talking about racial capitalism. I do believe that the capitalist system of extraction is based on othering. And so I think I was just saying it in a different way without using that category. But you're right. If you use that category, then moving beyond to achieve global health equity, we may actually have to even abolish global health. We may have to get to this. In most presentations, we end up on this. Does what we're talking about, if you take it to its logical conclusion, get us to Trotskyism, right? Get us to this global socialist movement where we abolish the system of racial capitalism that essentially others so as to justify extraction. So yeah, I am talking about that. I didn't use the term, but you're right. And would maybe the step after reparations is moving beyond racial capitalism, because what my colleagues have to say is that we can never get to these post-racial states. We can never even get to the movements where we want to transcend this othering without repair of the previous legacies. So maybe once we get to repair through reparations, then we're in the position to move beyond what is, as you accurately say, global system of racial capitalism.
I'm going back to the Q&A box, and we'll ask Deepika Joshi's question. Jean, you talked about colonial relations between the North and the South, but there is also the aspect of colonial relation between actors within the South. For example, the Indian state vis-a-vis Kashmir and Northeast India, or Indian state vis-a-vis the tribal populations, and so on. You already talked about Sukhdev Thorat and his work on caste. There is already some work on how relations between state and indigenous populations impact health policies. How, in your opinion, such relations impact knowledge production and policy making in the health sector, and any specific dynamics exist with regard to a pandemic situation?
Yes, and so again, this gets beyond my expertise. In the Lancet Commission, we only had room really for 10 different sections, even though there are thousands of hundreds of thousands of relationships around the world that would lend themselves towards exploring reparative justice. I think the Sukadev's exploration of caste is novel in that it's different than the nation state being charged for colonial atrocities and whatnot. But you're right, there's also the relations of state and indigenous populations. We did focus on that in the US because that's something I'm closer to, and one of my colleagues, Joe Gahn, has worked a lot on historical trauma among Native Americans. And so we do have a section on that. And I guess the goal of the report, which comes out this summer, would be to just give an example of how all, various different groups that have, claims for reparations can go about, documenting these claims, researching them, making recommendations, supporting grassroots movements to actually fight for them. So yes, to me, it's all kind of a similar dynamic of coloniality. But again, me, myself, and the group I'm working with only have a delimited number of cases we're working on, but the hope is then this expands to a network. We would want to have a huge conference afterwards, inviting all, various groups that have, different relations to bring to the fore, so that we can all learn from each other and work in solidarity.
I'm not asking every question either in the chat box or in the Q&A, because some of them, as Jean has been saying, are looking somewhat outside the scope of his work. So some of them are not asking, but I'll ask one question. Adarsh Adhikari, could you please elaborate on the ways how the world can cope with the results the colonialism has brought about in terms of global pandemics and the solutions for that? This is in Q&A.
Mm-hmm. Yeah, so I think that, and I keep falling back on this, reparative justice notion that, so for example, there is already talk now about, for future pandemics, building a series of mRNA vaccine manufacturing centers across the globe, so that in a future pandemic, we can easily have the capacity to get the billions of vaccines we need. But they're already talking about, how would we pay for this? Is it going to be loans from the World Bank, and how are they going to be paid off? And I think this is where the idea of reparative justice can come in. We're already totaling up the trillions that are owed. This vaccine equity and pandemic preparedness can serve as an initial stage of reparative justice, where the countries that have done the extracting need to pay for these because one, it's just from a historical perspective on the amount of money that's owed. But here is the example of everything else that's been done in a colonial fashion has essentially hurt the oppressed part. But now that we're getting the climate change and pandemics, the global north is starting to see it come back upon them. So even beyond the moral, legal, and historical arguments that reparations are owed, is the argument that to save yourselves, you're going to have to start paying back what was stolen.
So there is one comment rather than a direct question about super spreader from Dr. Anthony from Kochi. I don't think it really needs an answer, but I will read that. A prejudice, super spreader, is it super spreader a prejudice-laden terminology to be abandoned in modern epidemiology, where the unfortunate patient is blamed and the health and social system which made the person a victim of disease escape unblamed? In India too, migrant workers and minority religious groups assembled for a religious congregation were blamed super spreaders. And I will simply make a comment on that. I know it is not for you to respond, but the super spreader events are in India, at least they look as if they are related to religion and not to reality. Because I suspect the Kumbh Mela as it is going on in India, that is not at all claimed to be a super spreader event, even if we use the same terminology, which is prejudiced and biased, same terminology, because it's a majority festival, it is not blamed, is how some of us would like to put it. But Marcus this time last year was blamed as the super spreader event. Because it was from Muslim minority, it got undue publicity and real name calling for it, which is what Dr. Anthony is actually referring to. And I think we have probably gone much beyond our time. There are quite a few questions which are still pending. And since I used Dr. Anthony's question as to comment a little more, I suspect I would stop there and hand it back to whoever is going to say the last few words. Sarojini, your hand is up, and is it only to remind me that the time is up?
No, I don't know why it is there. No, I did do that, but it's coming there. Yeah, I'm not.
That's okay. But the ball is in whoever's court now.
Yeah. Chayanika, would you like to say anything now?
I just wanted to add a couple of things.
Yeah.
I think that this idea of using a term like coloniality even for pre-colonial oppressive relations is one way of seeing it. And I think if you look at Kancha Elias Shepard's work now, he's also referring to some such understanding in the caste system. So I do appreciate this, but I think a lot of concerns that are there in the questions are because India is in this funny location of having, being a colony of the past, but also being a major superpower in the region and having its internal colonizations of various kinds. So I think we're all responding to your talk from these various locations and trying to figure out how do we apply it to our context. But I think there are a lot of questions which maybe, since we have them here, we could send it over to you and you could type in your answers, or I don't know, how do you want to take it forward? But thank you very much for that conversation.
It was a wonderful talk.
Thank you very much, Jane and Vineeta. I request Nilanjana to take it forward and then close the session.
everyone, the speakers, the facilitators, and the participants who joined us today at such a late hour in India and probably early in other parts. There were several friends who could not join us because of different time zones, and we'll make sure that the recording of this webinar will be uploaded on our website. Our first webinar with Dr. Prashant Kadambi and Dr. Carlo Kadaf is already up on our websites, and you guys can access it now. Sama had initiated the series of conversations to develop a holistic understanding on pandemics and public health, especially trying to interlink between our experiences in the past with our present situation that we are dealing with COVID right now. And I think our both webinars that have happened in the past few weeks have shed light upon various perspectives and kind of help us gain an insight into what the situation is across the globe. Once again, I would like to thank everyone on behalf of the entire team of Sama and PHM Gender Justice Health Thematic Group for joining us today. And we hope to continue these engagements with you guys in future as well. Have a nice day.
Thank you. Thank you all.
Yeah. Thank you all. We will be continuing these, may not be in the current context what we are right now, but I'm sure, it may not be the same fora, but in other forums also, we will be taking these discussions forward. And we would be sending you the questions, Jean, and maybe, some of them would like to know from you because you have already given the email ID. And thanks so much once again to everyone, Vineeta, Jean, Chaya, and everybody. We will be, we are, trying to develop a feminist and public health understanding on this entire issue. In that, this is one part of it, looking at the pandemics and then what are the lessons we learned. And then that will continue with science and technology and other equity and intersectionality. So this is a comprehensive picture. And then we thought this will be, setting the ground for us, which, Chayanika and I are trying to put together and then make sure at the end, we will come up with the way the feminists and public health will understand this situation now. And thanks once again, stay safe, and then we will be in touch. Thank you all.